Hej, Jenny Harrison heter jag.
Och Mikael Bengtsson heter jag.
Vi jobbar som sjukgymnaster här på Strandhälsan i Falkenberg. Vi har gjort en kort film om klinisk pilates. Och vi tänkte börja med att presentera lite vad klinisk pilates är för någonting.
Traditionell pilatesträning innebär stabiliseringsträning och syftar till att kontrollera kroppens leder för att minska smärta och besvär.
Skillnaden mot traditionell träning instruerad av sjukgymnaster är att den här träningen är mer konsekvent. Man undviker att ge träning i alla riktningar utan håller sig till den riktning som gynnar patienten. När sjukgymnasten är konsekvent i sin behandling kan man använda träningen som ett diagnostiskt verktyg. Om sjukgymnasten enbart ger en patient flexionsövningar för ländryggen och patienten blir bättre, så kan vi utesluta skador som skulle göra patienten sämre med flexionsövningar. Till exempel posterior diskbråck. För att veta om patienten blir bättre eller sämre med de givna övningarna testar sjukgymnasten alltid patienten med flera olika test. Både strukturella, till exempel straight leg rise, och funktionella, till exempel enbenshopp. Testerna ger direkt utslag åt ena eller andra hållet beroende på om övningens riktning gynnar eller missgynnar patientens funktion. När sjukgymnasten är konsekvent i sin behandling så har man större kontroll över vad som gör patienten bättre eller sämre. Man kan därför uppskatta patientens prognos lättare. Sjukgymnasten kan också ge besked till patienten och övriga vårdgivare om diagnos och prognos. Utvärdering gör vi med hjälp av den patientspecifika funktionella skalan, där patienten uppskattar sina funktionella besvär på en skala 1-10. Detta sätt att instruera träning är nytt för svenska sjukgymnaster och är ett sätt att öka kvalitet på sjukgymnastisk behandling. I Australien pågår för närvarande forskning där man tittar på kostnadseffektiviteten av mer specifika träningsprogram anpassat till individens behov. Strandhälsans sjukgymnastik arrangerade en kurs i klinisk pilates i april 2010. Grundaren för konceptet i Australien, sjukgymnasten Phillips, kom till Falkenberg för att hålla den 4 dagar långa kursen, nivå 1 och 2 Clinical Pilates. Under ett tillfälle hölls en presentation av metoden för de läkare som vi samarbetar med i Falkenberg. Här följer ett utkast av den presentationen.
Briefly, what we've been teaching here is a process that we've been doing now for about 15 years in Australia. It's an exercise-based program. The thing with the exercises is that they are specifically designed to fit within each patient's requirements. We've been doing it initially with dancers. We were working with dancers in the performing arts industry, which is like sports medicine, except they've got 7 games a week, not 1. So you've got a high turnover there, you've got fast return to work. We've been working with sports medicine, we've been doing processes with the Australian Institute of Sport, working with a lot of the AFL teams and sports teams in Australia. We're now currently working with Premier League teams in the UK as well. So the same approach is now being applied into the sports medicine model. And again, cost effectiveness, sports medicine is very keen on reducing the expense associated. They pay ridiculous amounts for some of these players. You don't want them injured. We want to get them back on the field playing as quickly as possible. So they've got a vested interest in being able to figure out how do we manage this person. They're backing away from surgical management. As we've seen, there's a lot of studies being done on surgical management. Surgical management of osteoarthritis of the knee. There was a study published 2 years ago, Mosley study done in the US. 300 knees were arthroscoped, placebo and intervention. And at the end of that, it was a veteran study so they could do it with war veterans. But they found there was no difference in the outcome between the placebo group who thought they'd had surgery. Like they woke up, they had 2 nicks on their knees, they thought they'd had an arthroscope, and the group who had had the arthroscopy. That was published by Mosley. So that's been taken on board because this again is what's being looked at in the system, is the surgical outcomes have not been measured terribly effectively over the years. So the hospital systems in Australia, they're now looking, saying we want to know what the long-term outcomes are of these various procedures that are being done. They've done it with low back, lumbar spine, and seen lumbar spine surgery. There's a small group that do get better. Then there's the rest of them. So it's being able to, at the primary model, say here's how we triage out these people that are actually going to do well with surgical management. Here's how we keep these ones who aren't going to do well in the system that will actually give them the best outcome.
This program that you present, have you heard from Jenny or her partners anything about Swedish physiotherapy in the traditional form? Can you say anything about the differences between what you present here and what we in Sweden have seen for the last decade or so? What's the...
I guess the main thing is Swedish physio has been very exercise orientated for a long time. Still there's a lot of manual therapy involved, same in Australia. The same as is happening in the UK as has happened in Australia. The last probably 10 years the evidence and the literature has gone towards subgrouping. So rather than giving a wide range of exercise management to a group of people, is actually subgrouping these patients. So it's using the same model but actually being much more specific to the individual. So you can actually test the radiological findings. You know, if you see a large disc bulge on a scan, doesn't mean the disc bulge is causing the problem. So you can have a false positive very easily. You know, what you see on a scan sometimes may be, you know, you've got a nice disc bulge but it doesn't match the patient presentation. Or at the same time you might see the scan looks completely clean and the radiology shows something different. What you see on the scan needs to fit with what you see in the patient. So if I get her in this position, in relative prone, feet together, alright, just bend your right leg for me, lift the leg, extend it, and then put it down. Do the left leg for me, lift it, and is that more effort on that side? Okay, so bend the right leg,
what it does
lift it.
Feeling what happens underneath his fingers as well, activation.
And the same thing here, from bend the left leg, lift it. It's far weaker on this leg. If we take her across this direction, okay, bend the right leg, lift up, that leg still works nicely. Do the left leg for me, lift up, that's easier.
Yep.
So she recruits the muscle better in this position. Okay, so if I'm differentially diagnosing, there's a posterolateral disc bulge here, that would fit. If she's meant to have a pars articularis defect, if she's meant to have a foraminal stenosis or a canal stenosis, compressing the structure here doesn't fit. So here's where you can start to differentially diagnose, but depending on how it presents. If I take her that way, over there, bend the right leg, lift. So the right leg's still fine, do the left leg. And, right, there. And, no, don't keep doing it. It's not working. So again, you know, if I've opened up the foramen on this side, and it's meant to be a spondylolisthesis or a foraminal stenosis, that should unload the nerve root, which would improve the conductivity. That's not what I'm seeing. If she's meant to have a disc protrusion here, a posterolateral disc bulge, compression here, propagation of the disc into the nucleus and the annulus, bulges out, compresses the nerve, would fit. So here's where I can start to be pretty specific, going, well, my radiology shows a posterolateral disc bulge at L4, 5. This fits. So it means that if I'm giving her an exercise program, I've established a predictor. So clinical prediction rules is a big factor at the moment, is looking at predicting the outcome of your intervention. If I give her an exercise program, the criteria is that we give her exercise that will be basically sustained in this direction, because that's the direction things work better in. Good, and down, there you go, bend. So we're going beyond the old traditional muscle strengthening model onto the next level. You know, this is what's being looked at in sports medicine. The idea of strong players are your better players has been debunked, you know. Lots of strong athletes still getting injured, aren't they? Very expensive injuries, you know. Premier League, 20, 30, 50 million pounds per player. The strengthening programs haven't helped them. So this is where we're looking at, if she's doing an exercise program that involves extension on this left quadrant, the clinical predictor is that will give the best result.